Okay, I'm Kathleen Digre, and I'm a professor of neurology and ophthalmology at the University of Utah, and I'm also been doing headache now for about 30 years. And tonight what I'd like to do is just talk, I've called this Headache 101, because this is just basic headache information. What do you need to know, and what do you need to tell your doctors? And I'm going to have plenty of time for questions at any point during this lecture. And if I'm not clear, you let me know, okay? So the first thing I want to talk about headache is some terminology. You know, we say headache. Well, we kind of mean head pain, right? But most people who have recurrent headaches actually have migraine. And migraine is more than just head pain. It has a lot to do with the way our brain works and the way our visual system works and the way our whole system is put together. And so when a person comes to a doctor for migraine or headache, there are going to be some questions that we're going to ask. There's no, at this point in time, no scan that you can like do a scan and say, oh, this person has tension type headache, or this person has migraine, or this person has cluster headache, and all these different terms and different kinds of headaches. So it's the history is what helps us know what people have. So I'm going to go through kind of the questions that a provider will ask a patient who's coming in for headache or migraine, just so that they understand the kind of headache a person has and understand any concerns that might raise a red flag that would tell us that we have to look further for different kinds of headache. Okay? So the first thing I do is I ask about family history. And that is because most people with migraine and with chronic headaches have a family history of headache. Now, you may think about this a little bit, and you may say, well, I don't think anybody in my family ever had a headache. But if you think about it, did they ever say they had sinus headaches, or they ever have any kind of headache whatsoever? That tends to run in families. So family history is really important because it sort of sets a genetic stage. It says, are you prone to get headaches biologically and from your genetics? And so that is why I really do look at that carefully. The second thing I try to go after is like early life, because people with migraine tend to have symptoms even when they're babies. So for example, babies who have colic, you know, crying babies that have colic, are more likely later in adult life to have migraine. Kids who are car sick as children are more likely to be motion sick and have migraine later on. Night terrors is another early childhood event that often can lead us to understand that somebody is going to be getting migraine. So I ask about that because that helps me understand, is this a person who has in early life even had markers that tell me that they're more likely to get migraine? Then I want to know what happens over the life. So let's say the person was car sick as a child, and then I go through school, high school, grade school. Did you miss school because of headaches? Because often that's another clue to me that these headaches have been bad or difficult to treat, and that they've had to see people along the way. And then what happened after high school? And then, you know, what happened after having a baby or in early life. And then I want to know, when did headaches become a problem? So was it after a head injury? Was it after a stressful life event? Was it just out of the blue? I used to have headaches, but they were infrequent and never a problem until. And that is where I want to find out what was going on during that time that seemed to start the headaches going. So it's what's happened over one's life. And I want to know about stressful life events that may have occurred that made headaches worse, or physical factors that happened, a head injury, something else that happened in their life in a patient's life that told me that that their headache started. The heart of the history, however, is going to be in each individual attack, so the attack history. Now, the attacks of migraine, it's what comes with the attack that helps me know kind of what's going on. So I'm going to want to know, where is the headache? Is it on one side, both sides? Is it in the front or back? So location. I want to know kind of the character of the pain, like throbbing, stabbing, ice pick pains, etc. And then I want to know a lot about what comes with it. And the key things that I'm going to ask about are light and sound sensitivity and nausea and vomiting. And I'm going to ask about tearing, redness of the eye, whether there's stuffy nose, puffiness around the eye, wherever the pain is. I want to know those, what comes with it. Because that, and I'll give you some scenarios that help me understand what comes with it, okay? And then what makes it worse? So if it gets worse with jumping up and standing up, or is it worse when you move around and are active, or is it worse, what conditions make it worse? Is it worse if you don't sleep? Is it worse if you don't eat? Is it worse if you're under stress? Is it worse after stress? Is it only on weekends? Is it worse when you have a menstrual period? Then I want to know what makes it better. It gets better after I sleep. It gets better after I eat. It gets better if I can go on vacation. It gets better if I go to the beach instead of being in the mountains. Those kind of help me understand maybe trigger factors and things that make headaches worse. And then I'm going to want to really query about red flags. Now, red flags to a doctor are, what are the things in this history that make you nervous? So headaches in somebody who's never had headaches before at all. No family history, no life history, no history at all. That makes me go, okay, what's going on here? What happened here to make this headache start? The second red flag for me is a headache that's very weird, like the sudden onset of the worst headache of somebody's life. That's not normal, okay? Because a lot of times we get headaches that come and go, but suddenly having a headache that is completely new, out of the blue, the worst headache of your life, that's, or repeated severe thunderclap or sudden headaches are the kinds of headaches I'm going to pay attention to. A headache that has some different features with it, like weakness or numbness or tingling, or those kinds of features. Many migraines can be associated with an aura, and I'm going to go through a few mini cases with you so you can see why the history helps me tell what's going on. And then a headache in somebody who has an underlying malignancy, or has had AIDS disease, or has had an autoimmune condition or something like that. Those kinds of medical conditions will make me more concerned about the history. I'm also going to ask about psychiatric history, only because there are many conditions that run with headache, comorbidities, and we'll talk a little bit about that. And I'm going to ask about medications that people have been on, preventative medications that you take every day to prevent the headache, acute medications that you take just when the headache occurs, what do you take for nausea, and what medications have you tried. And then what medications are you on that may even cause a headache, because sometimes there are medications that we take that we don't even know could cause a headache. Like some people can be put on things to reduce their cholesterol that can actually cause a headache. So niacin, for example, is something that some people, it's a vitamin that people get put on, and sometimes it gives people flushing and gives them a headache. Sometimes there are herbal products that can give people a headache. And so those are the things, elements. So let me give you some examples of people. These are examples of people I see in my clinic all the time. So the first is a 24-year-old woman. She has a family history of migraine in her mother and grandmother. she was carsick as a child, and then she started having headaches around her periods. They were never really bad. She didn't miss school, but after the birth of her first baby, she started having more frequent headaches. So it already tells you that this person was kind of predisposed to the headache. The headaches became going on. And now her headaches are unilateral, throbbing. She has light and sound sensitivity, nausea, and vomiting with her headaches. And sometimes she has an aura. An aura can be a visual aura. That's the most frequent aura that has like a zigzaggy line. And she gets that, and then she could get a headache. But not all of her headaches are with that. So this headache type is a migraine headache. And what makes it a migraine is light and sound sensitivity and the nausea and vomiting. You don't always have to have all of those things, but if it's severe and there's nausea and it gets worse with activities and there's light and sound sensitivity, that's most likely a migraine. Okay? So that's one typical case example. Another one is similar to a case I saw today. A person who is 30 years old, who has a family history of migraines, was a little bit carsick as a child, but really not having headaches, and then had an accident, and then it started having a chronic daily headache that never went away. But the headache is not like a migraine headache. It's a tight band-like sensation across the head. It's mild to moderate. There's maybe a little sound sensitivity, but no light sensitivity, no nausea, no vomiting, and it gets better with activity. And that's a typical story for a tension type headache. Tension type headache is not like tension, but it's probably on a continuum with people with migraine. Can you see how the history that I have to get from people tell me what kind of headache? Then here's one that's very different. So this is a 24-year-old man who has started having headaches that were very peculiar. They have abrupt onset of headache, and when it occurs, it's just over the eye, and he gets tearing, and his nose gets stuffy, and he gets a red eye. He gets a little bit of droopiness of his eyelid, and it's gone within 30 to 40 minutes, but it's really severe. Now that's not the same as those other headache types either, right? And that's how you use the history, how a provider will use history to tell what kind of headache a person has. And so that's a cluster headache. That is a typical cluster headache. Now sometimes the headaches kind of mishmash around, you know, like a little bit of this and a little bit of that, and that's where we have to really kind of try to figure out the different kinds of headaches that somebody has. But those are kind of some basic headache types that we're going after when we do a headache history. Do you have any questions about those basic headache types? Nobody?
I don't know if I remember what a headache is. Like just a regular headache. Are they only the cluster headaches that come and they go?
So when somebody says regular headache to me,
as opposed to a migraine.
Well, regular headache means that this person has always had some headaches, okay, or has had headaches in their family, and usually what that means is that people have migraine or chronic migraine, and then maybe a few tension type headaches that they consider their regular headache. So that's how I would interpret regular headache. Let's talk about what makes migraines, and usually the underlying problem is migraine, okay? Usually that's the underlying problem. Even the people who have just tension type headaches, they often periodically have migraine. But let's talk about migraine. So migraine is not just a headache, it's also, it affects your thinking when you have it, it affects your sometimes it affects your vision. It sometimes can make you dizzy. It sometimes can make your brain foggy when you have it. So it's, you know, it's not just a headache. It's all these other things that are coming with it. But we diagnose it when it has all the light sensitivity, the sound sensitivity, and maybe nausea and or vomiting, and gets worse with activity. But there are distinct things that make migraines more chronic. And these we go after because we don't want people to go from, it's kind of like, you know, if you have episodes of headache, like one migraine a month, okay? But then some people have more than 15 migraines in a month. And that's a lot of migraine, right? And so there are certain things that make migraines more frequent. And a couple of the risk factors for this are ineffective acute treatment. So when people are given medication to take for their migraines and it doesn't work, well, then they often will take more and more, and sometimes they can get into overusing medication. But the problem is that the medication never worked in the first place, and that begets more headaches. So more migraines beget more migraines, okay? Another factor that can make migraines more chronic is obesity. So talking about being overweight or obese is really important. Some of the two worst things that make migraines more chronic are stressful life events, and especially people who've had several stressful life events. Now, what's a stressful life event? A death of a parent, or a death of a partner, or a death of a really good friend. Death is like, I mean, if you've ever had anybody die in your family, you know how stressful it is. And then some people have multiple stressful life events. A divorce. Either your parents get divorced for a kid, it can be very stressful, or your partner and you get divorced. Well, that's extremely stressful. So divorce, moving, new jobs, stressful bosses. I mean, bosses that go ride you hard and micromanage you. I mean, you know, when people are trying to do their best and somebody's trying to these are stressful things. And some stress is not the same for one person or another. So one person may think that it's stressful to, you know, have somebody picking on them every day at work, and some people would say, I don't care, you know, and that doesn't stress them out. But each one of us is very different on how we perceive the stress and how it affects us, right? So it ends up being very important to try to recognize if there have been stressful life events, because these can lead to more migraines. The other thing is overuse of medications. So rebound or medication overuse headaches can make migraines more chronic. And if you take an acute medication, so now I'm going to talk about, you know, taking acute medicines and prevention and all that. But if you take an acute medication more than 3 times in a week, you're at risk for medication overuse headache, but also at risk for getting into chronic migraine. So it ends up being a really important thing to not overuse medication. And then depression and anxiety. Now, depression doesn't cause migraine, but migraine and depression are closely linked. So the more depression there is, the more migraine there can be. And some people say, well, I wouldn't be depressed if I didn't have all these migraines. And I go, wow, you might not have all the migraines if you didn't have the depression. Do you know what I mean? They're so intertwined together. And these are well-known comorbidities. As depression increases, migraine increases. And these have been studies that have been done. Anxiety is really interesting because anxiety may make people fearing they're going to get a headache. So then this sort of builds up, you know, oh, that little headache I've got right now, ooh, I wonder if that's going to go into a real migraine, or is that going to get worse and worse and worse? You know, so anxiety plays a role in making migraines worse and more chronic as well. Snoring can make migraines more chronic. And why would that maybe be? Well, sometimes it is that people have sleep apnea, or maybe it's related to poor sleep. And sleep is, when I talk about getting better, sleep is one of those factors that if you don't sleep well every night, you just have difficulty getting better. So those are some of the things that make migraines more chronic. 1 to 2% of the population, we're talking about a lot of people in the United States, have chronic migraine. 1 to 2%. There are 36 million people in our country that have migraine. That's a lot of people. And migraine is listed on the WHO website as one of the in the top 10 most disabling conditions to have. So it's it's a problem that we really need to deal with, and that's why we do these lectures to try to understand, and that's why we're doing this basic Understand Migraine and Headache 101. Any question about chronic migraine? Okay. I want to talk a little bit about medications. Well, first I want to talk a little bit about what would a visit to a doctor look like with headache. So the first thing is going to be history, and history is the key, because we don't have a machine that you can go into. I'd love a Dr. Seuss machine that you could go into and say, this is the kind of headache that this person has 3 different kinds of headaches. They have migraine, they have a tension type headache, and they have an episodic ice pick pain. That's a sharp stabbing little jabbing pain. Okay? I'd love a machine like that. And then I'd love a machine that you go in and they say, and put them on this medicine because that will prevent their migraine, and this medicine, and it'll take away the migraine if they get it. But we don't have that. So it's, again, one of the things about headaches and migraine is you have to talk and communicate. And the more you understand about migraine, and the more you can give your provider information about your headache, the better they can help you. Because if they understand your headache, they're going to be able to think about all the different things that could make you better and help solve the headache problem. So the first thing a provider will do is a history, and you can tell there's a lot of parts to the history that we have to go through to understand all the different aspects of the headache. The second thing is an examination. A doctor should listen to the heart and the lungs and look in the back of your eyes, because there can be clues in the eyes that can tell you that the person has a different kind of headache, a secondary kind of headache, like high pressure headache. And then they should do a complete neurologic examination, because everybody who has migraine or headache should have a completely normal neurologic examination. Otherwise, you can't diagnose migraine. You have to figure it out. So examination. Then the other thing that may happen is imaging. Now, we don't image everybody who just comes in with a headache, because if I do imaging on people who have typical migraine, 100 people with typical migraine, no red flags, no funny history, nothing wrong on the examination, maybe only 3 people will I find something, and it may not even be important. It might even be incidental. So we don't image everybody with migraine, only those people that have some problems that occur with it. But for sure, we want to talk about treatment and what do we want to do about treatment. And the kinds of things that I am always the way I divide treatments is first getting the right diagnosis, making sure that everybody that I see has a diagnosis of what's their headache type, and they may have more than one headache type. It may be chronic migraine, episodic stabbing headache, episodic tension headache. People can have multiple headache types, and you tell that by the history. And then, so I want everybody to know a diagnosis, and then I want everybody to know non-medication treatment strategies, because medications only go so far. And so some of the strategies that we talk about are trigger factors, knowing your own trigger factors. What do I mean by that? Well, that means that some people have definite factors that trigger their migraines. So for women, menstrual cycles are very typical trigger factors. And if you know that, we can design treatments like mini preventives around the menstrual cycle that can prevent that migraine from occurring. I want to know if it's triggered by certain types of food. Now, some people have eat every time they have aged cheese or eat hot dogs because there's MSG or nitrates in it, they get a headache or a migraine. Or red wine is a big trigger for a lot of people. Well, if you know that, then you know that you're going to be at risk if you go for one of those trigger factors of what you eat. But some people go on extensive diets where they eliminate everything and they still get migraines. So diet is not everything, but I think it's important for everybody, because we're each individuals, and our migraines and our headaches are each individualistic. We need to know our own trigger factors. So diet. I always say the main thing about diet is to eat regularly, don't skip meals, because if you skip meals, fasting for some people is an immediate trigger. And avoid sugar, because some people get that sugar rush and they can get a migraine. And stay hydrated. And especially in states like Utah and desert states, and especially in the summer, it's easy to get dehydrated, and that can really produce headaches in a lot of individuals. Now, there are other factors that can trigger headaches as well, like altitude. Now, we live in a higher altitude state, and some people go up higher in the mountains and they can just say, I'm going to get a migraine if I go into the mountains. And it's always important for people to notice whether they get fewer headaches at low altitude and more headaches at higher altitude. Think about when you go on vacation. If you go to a different place, do your headaches change? I think that's knowing whether the altitude plays a role or not. It may or may not. There are some evidence to suggest that aura may be more common in the mountains, and depression has also been found to be more common at higher altitude, which I think is really interesting. Nobody understands why that is. Altitude. Weather. You can't change the weather, but if you always know that when a front comes in, you're going to be more likely to get a headache, you might be more prepared to prevent it. Okay? Light. Does light trigger your headache? There are some people who are very visually sensitive, so lights like this, fluorescent lights, can trigger migraine headaches in some people. Computer screens can trigger migraines in certain people. So if you know that you're light sensitive, we have treatments that can help people who are light sensitive to prevent migraines. And I can talk about that. Other trigger factors, not sleeping. If there's one factor I can say that I can almost guarantee anybody with migraine, if they have it, if it's not sleeping. Okay, sleep is incredibly important. That's when our brains get rid of all the toxic chemicals and all the weird stuff going on, and it's when we reset. It's kind of our reset button. So if we don't sleep at night, we're not going to get our headaches under control. So it's critical to sleep at night, and that's one thing I always stress is sleep is really, really important. And then I talk about stress and anxiety, because if stress triggers migraines, I always want to address that with certain websites that can help us with relaxation and mindfulness. And all of our patients get a list of websites that have, and you can go to our website of the University of Utah Headache Clinic website, and on that website we have a little booklet that has resources for mindfulness and everything else. We have a little booklet like this that's free. You can download it. It's even in color, and it's available to everybody free on the website. Just Google University of Utah Headache, a patient's guide, and you can get this guide. All right, I'm going to talk about the things I talk about with other, so knowing your triggers is important. And then I also talk about exercise. A little bit of daily exercise is really important. I treat exercise like medicine. I say 10 minutes every day, at least 20 minutes, 5 times a week where you get your heart rate up. It's really important because it will prevent headaches as well. So we really stress exercise. Then I stress this mindfulness, and we have a couple websites, about 4 websites that you can visit. One of my favorites is dawnbuse.com, DAWNBUSE.com. She's got a psychologist. She actually did some training here at the University of Utah, so she's kind of one of us. And she's out in New York right now, but she has a fabulous website that has a lot of resources on it for mindfulness. UCLA also has a great mindfulness website, and there's even a trigger point workbook, and all of this is on our website. And then we stress diet, eating, protein and avoiding sugar. We stress hydration, minimum 72 to 96 ounces of hydration. We try to stay away from carbonated beverages, not only because of the sugar, but because of the NutraSweet and other artificial sweeteners. For some people, can be a trigger. Then we stress caffeine. Caffeine more than 8 to 12 ounces a day of caffeine can make headaches markedly worse. And so we have to watch that. And then sleep hygiene. So we say to all of our patients, our sleep hygiene is in bed for 8 hours, no other activity in bed except sleep and sex, and avoid large meals before going to bed, because not only does it make you have difficulty falling asleep, but you always have to get up to urinate, and that disrupts sleep as well. So, and then watching your trigger factors. So those are our non-medication mechanisms that we use for treating a headache. Now let's just talk about medications. So I remember I said I divided treatment into knowing your diagnosis, and I do believe the more you know, the better you do. And the more that you know about your kinds of headaches, the better you do. So knowing your trigger factors and preventing them that way. Knowing all the non-medication preventatives that are out there, okay? And then medication. Now we divide medications into 2 types. One is prevention, and the other is acute treatment when you get a headache. So let's just talk about prevention. And we do a whole lecture on medications. So, and I hope you'll attend when our pharmacist comes and talks about all the different medicines and everything, because this is going to be a very, I'm going to call it a very summary of the medications that are out there, the classes of drugs that are out there. So there are many different medications that prevent migraines and prevent cluster and prevent all the different kinds of headaches people get, even tension type headaches too. But these classes of drugs are first blood pressure medicines have been out for preventing migraine. And examples of these are like propranolol or Inderal, Nadolol or Corgard, and Verapamil or Calon. And there are very many other blood pressure medicines. And they sometimes work for people to prevent migraines, especially if they've got a little bit of high blood pressure. We frequently will choose that as a preventative. So that's one class. Tricyclic antidepressants. Now these are old antidepressants. We don't use them for depression anymore, but they're great for preventing migraine. And these are things like amitriptyline, nortriptyline, imipramine, dizipramine. There's a whole bunch of these, okay? And each one has a different side effect. I like it for people who can't sleep, because it helps people go to sleep at night and will prevent the migraine as well. So that's a really good class of drug. A third class is anticonvulsants. And the 2 approved by the FDA for migraine is topiramate and valproate. Those are 2 approved by the FDA, the Federal Drug Administration, for the prevention of migraine. And topiramate has a nice side effect of weight loss, whereas valproate has the side effect of weight gain. And not many people like the weight gain side effect, but it's a very effective drug. Yes?
The dox is the one that starts with the DOX. Is that, do you recognize that? I thought it was the
Dizipramine?
I must not be remembering.
Zonisamide?
No, it's a D, and you gain weight and you lose your hair.
That's valproate. Okay. Yeah, you're thinking of Depakote is the trade name for it. Yeah. Okay. Yeah, that's valproate. It's a very good drug, though. It does really work for migraine, but it does have side effects.
What about zonisamide?
Zonisamide is another anticonvulsant. It's closely related to topiramate, and it has been used in preventing migraine. It's not been studied in migraine as much as it's been studied, for example, in seizures. And it's not approved by the FDA, but we frequently use, in headache, we use as many things as we can to prevent migraine, because, we have to have as many things. We often use herbal products, and when we have the pharmacist come, please come, because she'll talk a little bit about herbal products. What kind of herbal products are used for prevention of migraine? Magnesium, for example, riboflavin, which is vitamin B2, coenzyme Q for some people. Butterbur has been used, although there's been some controversy about whether there's a problem with the butterbur and liver function tests. So we aren't using that at the moment as frequently until we can kind of know whether there's a safety issue. Okay? So preventatives, and there's many, many more. On our website, this little booklet has, I'll show you how many pages we have on prevention, just so you can see many, many pages of medications that we use for prevention. Muscle relaxants, sleep agents, etc. Okay? Then acute treatment. So prevention you take every day to prevent a headache from occurring. But even in the best of hands, we still get migraines and headaches even when we've got preventatives. So then for treating an acute migraine, there are 3 principles that I stress. One is treat nausea, because sometimes nausea ends up being so disabling you can't work because you're nauseated. Treat the pain and try to get rid of the migraine, and when all else fails, sleep. Those are my 3 principles. And there are medicines out there in all 3 of these categories for that. So for nausea prevention, we have medicines like metoclopramide, ondansetron or Zofran, promethazine or phenergan, prochlorperazine or compazine. These are preventatives for nausea. Pain. Now, there are non-specific pain medicines, and there are specific pain medicines for treatments for migraine. The non-specific ones are things like acetaminophen or Tylenol, aspirin, Excedrin, ibuprofen, naproxen, Aleve. Those types of medications are non-specific medications for migraine and headache. And for some people, that works just great. But some people need specific migraine treatment, and those are the triptans. Sumatriptan, naratriptan, zolmitriptan, elatriptan, rizatriptan, frovatriptan, and elmotriptan. And these are excellent migraine, and they're really a designer migraine drug. That's how they were founded. They had a certain chemical that worked for migraine, and they put side chains on it to make you not nauseated. And for some people, these changed their life. And there's different ways of getting the medicines. There's pills, nose sprays, there's shots for sumatriptan shots, and some of them have been compounded to be the sumatriptan plus a little naproxen with it, another drug called Treximet. And then there's some novel delivery devices of nose sprays that have come out. So those are the acute treatments. We try to avoid narcotics, and here's why. Narcotics sometimes make people resistant to specific migraine treatments, and because they can lead to more medication overuse and rebound. And I don't know if you've read the newspapers, but there's an opioid epidemic occurring, and narcotics are not a good treatment for chronic migraine. Occasionally they're used, but they should not be a first line, second line, or third line, only in certain circumstances. And then sleep. What could you take that could help you sleep? So diphenhydramine, which is Benadryl over the counter, sometimes that helps you sleep. And then there are other sleeping medicines that people can use to help sleep with a bad migraine. So that's kind of the basic medication treatments. There are some new things on the horizon. I do want you to know there's new treatments on the horizon. A whole new class of drugs, calcitonin gene-related peptide inhibitors and antibodies to calcitonin gene-related peptide. And in some of the early studies that are coming out right now, they're very promising, but it's a completely new class of drug designed for people with migraine. Okay? I also want you to know there are a lot of devices out there for both preventing migraine and treating migraine. And we are going to do a whole night on devices. So make sure you come when we'll bring all the devices and you can see them all and try them and things like that. But there's a whole group of devices out there for preventing migraine, such as a supraorbital transcutaneous stimulator. It's called a Cephaly device, and that's been FDA approved for migraine. There's a transmagnetic stimulation device that's been approved for migraine with aura, at the onset of the aura. There is a vagal nerve stimulator that's been approved for cluster headache. So there's a lot of new devices coming out all of the time. There's another device called a Sphenoid Cath, where a little thing goes up your nose and gets lidocaine squirted up the back of the nose. So there are these new things that are coming out, and we'll do a whole session on just those because people like to know about these new devices that are coming out. So now I've gone through what your doctor is going to ask you when you go in, or your provider is going to ask you when you go in to find out what kind of headache you have. I've gone over the kind of basic headaches of migraine, tension type, cluster headache. There are many, many different subtypes of headaches. We've talked about red flags, about what would make a doctor go further in looking at other things that could be causing them. And we've talked about conditions that make you have more chronic headaches. And we've talked about treatment, kind of an overview of treatment. And this is real basic stuff tonight. I'm not very in-depth, but just kind of what are the basics that you need to know. So I want to make sure that I leave plenty of time for questions that you might have.
How do we find a provider?
Okay, so a question is, how do you find providers? And you know what, that's a good question, because you know, bless our family practice hearts, people are busy and they may have 10 minutes to see a patient, and they've got 10 minutes, 10 minutes, 10 minutes. And I mean, when you've got migraines and you've got, look at all the questions I want to ask you about your headaches, it's really hard to have enough time to see the patient. So how do you find providers? Okay, one, I would go to the American Headache Society website, the American Migraine Foundation website, and say, get a provider. These are doctors, and some are family doctors, some are internists, some are neurologists, but they're all people interested in migraine and in headache. So that's one way to find a provider. The American Migraine Foundation, it says, find a provider. And you can go right there and find a provider. Neurologists are trained in migraine. So neurologists are another great source. And there's some really good family docs and primary care docs that love headache and do a fabulous job in taking care of people with migraines. So it doesn't always have to be a neurologist, but the main thing is find somebody who kind of likes taking care of people with migraine and likes the subject and embraces it and makes it, and they want to understand it. Because those are the people that really are going to care about you and your migraines, okay? Another resource is within the American Migraine Foundation, we have a patient support group, the American Headache and Migraine Association, AMA. It meets usually 1 or 2 times a year, and it's like Headache 101 for everybody. Anybody can go to it. You sign up. Doesn't cost too much. Again, you can find information either on the American Headache Society website, the American Migraine Foundation website, or the American Headache and Migraine Association, AMA's website, and when their meetings are. But learn all you can. And I'm so glad to see you all here tonight just getting some basics, because the more you know, it's one of the guarantees I have, the more you know, the better you do. And it's kind of like if you had diabetes, they'd send you to diabetes school. And that's why we started this headache school, is because we want people to understand all the ins and outs about headache and migraine so that people don't suffer. We don't want people suffering. So I'd say find somebody who likes the subject, and you can even ask them, like, do you like to take care of people with headache? And if they go, you know, I avoid it like the plague, oh, maybe that isn't the right person to start, or if somebody says, yes, I go to all the meetings, I try to study it, I try to learn everything I can, I'm up on everything, that's the kind of person you want.
What about Botox?
Oh, I'm glad you brought it up. I should have talked about Botox. It's a treatment for chronic migraine. So Botox is onabotulinum toxin, and it's taken from botulism toxin, and it's injected in, it's shots in the head in various places, and it's been approved by the FDA for chronic migraine. So it's not for episodic migraine, it's not for tension diabetic, it's not for cluster, but it's been approved for chronic migraine, migraines that occur more than 15 days a month. Most insurance companies will approve it if you have failed 3 preventatives. That's why I went through the different classes of prevention. You have to have 3 different classes of prevention. So that's, otherwise insurance companies don't pay for it, and it is expensive. I mean, it does cost money. How does it work? First, it may be working peripherally on the nerves around our heads, so that is something that could be tried for people with chronic migraine. Often you have to try it 3 times before you say it doesn't work. Sometimes the first time will work a little bit, but not enough, and the second and third time may work. So we usually say 3 trials to try to see if it works. For some people, it's like a switch that reduces the number of headaches, then their preventative works better, their acute medications work better, and they do better. For some people, it doesn't work at all. And so it's very variable between people. And it's impossible to really tell who it's going to work on. But for some people, it's a game changer. So we frequently will send people for onabotulinum toxin therapy.
So I have chronic, like all the time, migraines. It's just how bad are they? And we've done the box over a year. At that point, do you say, yeah, that's some of those it doesn't work on?
I'm sorry, I didn't hear the last part.
If I've done a series of, I'm probably at 5, maybe 6 shots now.
And it's not working?
I still have
chronic migraines.
chronic migraines.
So that's where I would, maybe have a frank discussion with the provider about, are there other therapies that you might try? Because there are many therapies to try. And one message I have is don't give up at all. Never give up, because we're not going to give up, so you can't either. Okay? It's important to not give up. Often when I see people who have gone to many providers or whatever with chronic migraine, sometimes the diagnosis isn't quite right. Maybe there's the migraine diagnosis may or may not be right. The comorbidity diagnosis, and we talked a little bit about what these comorbidities are: depression, anxiety, other factors that are driving the migraines to occur aren't being adequately addressed or treated. And so we always look at that factor. The other thing I look at is what medicines people have been on, because sometimes they haven't been used at the right dose for the right amount of time, because sometimes you have to be on a preventative for 2 to 3 months before it's going to work. And so it's some things that, there are many, many times we find little clues about why things aren't working. So don't give up. I just want to say don't give up, and keep working and work with your provider, especially a provider that, remember, you want a provider that loves to study headache and go to headache meetings and things like that when you have chronic migraine. Yes?
What's the best time for sleeping?
Pardon?
What's the best time to sleep 8 hours from?
Okay, what's the best time to sleep the 8 hours?
Yeah.
At night.
Yeah, I know, but
But some,
you want to sleep from 10 to 6 or from 11 to 7?
so people who have, and I hope I understand your question right, okay? People who like have to stay up all night long, that's really hard for people with migraine. Because migraine brains they like routine. They like to go to bed at a certain time, get up at a certain time. That's best for their brains. And so when people don't sleep well at night, or have jobs that keep them up all night, sometimes I work with them to try to work with their employer and everything to find a job that can have a period of time for sleep. If you have shift work, it's better to just stay on one time zone for your brain. And then have it really dark, because darkness does turn off the brain a little bit. So some people with migraine have to wear little nightshades to bed because a little bit of light will keep them awake. But darkness seems to help put people to sleep. Does that answer your question? Did I understand it properly? Okay, great. Any other questions?
How many of your migraineurs have dizziness, not vertigo, but dizziness?
Okay. The question is, how many of people with migraine have dizziness or vertigo? And I would say a lot. It's a very common accompaniment to people with migraine. In fact, I think we did, I don't know if one of our lectures talked a little bit about that, but there's a whole, we didn't go through all the migraine types and all the things that go with migraine, but vertigo is a big portion of people with migraine. And that is interesting because vertigo can make the migraines worse and migraine can make the vertigo or dizziness worse. So they go together. And I only saw 2 people with that today in my clinic. So you're not alone. There's a lot of people out there that have it, and I see a ton of it. It's usually people who are very motion sensitive, like carsick as a kid, and kind of motion sensitive all the time, that seems to make that worse.
And do you have a treatment that seems to help?
Yes, there are definitely medications out there that seem to help that, and helping get the dizziness under better control is a good idea too. And sometimes we send people to the Hearing and Balance Center to understand where the vertigo is coming from. If the person has Meniere's disease or some other dizzy condition, we work on that. Yeah?
For your devices, is it the same thing that you can't really predict who would do well with a device?
Okay, the question is, with the devices, can you predict who's going to respond? No. I'm afraid there's a lot of trial and error in this migraine headache world. And I wish we had magic wands, because we could then take care of everybody, right? But and I wish I had that magic machine that said this person will respond to this. Do you know what I mean? But we don't have that yet. I'm hoping someday we'll cure migraine and cure headaches. But I really believe that it's right now there is some trial and error involved, and listening to what people have to say is the most important thing. Is where I get my clues of what to do. Well, I think our migraine yoga, headache yoga teacher is here to get everybody into headache yoga. And I don't want to keep people longer than we try to stay on time. Please visit the website. If you can't come every week or month, visit the website and you can listen to lectures. There was a fabulous lecture, for example, on post-traumatic headaches, fabulous lecture on the pathophysiology of migraine. I urge you to go to that one, because it goes through how your brain works in migraine and why it gets complicated, why people get dizzy, why people have light sensitivity, why people have the pain, and how all these pieces work together in the brain. So I urge you to visit our website and go to that. So thanks for coming. And if I can help in any way, let me know.
I think, did you start at 6?
Pardon?